Okay, we're ready to start, Councillor Hutton.
Good evening, everybody. Welcome to the Adult Social Care and Health Scrutiny Committee. Agenda item 1 is declarations of interest. Can I ask members present if we've got any declarations of interest, please? I'm going to take that as a big fat no. Thank you very much for that. We then come on to the minutes of the last meeting held on the 17th of March. Is it your wish that I sign them as a true record?
Yes, please.
Everybody happy with that? Okay, thank you for that. We then come on to public speaking. I'm not aware of any public speakers. Sharon?
None today, no.
Right, thank you very much. That then brings us on to agenda item 4, avoidable readmissions. Who's leading on this one? Can I, before we start, I'm assuming that everybody's read the reports, and can I ask those that are presenting to just keep it as brief as they can without skipping over anything? But if somebody wants to just update us on the information, then please do so. Who's gonna? Is anybody?
So we've got Peter.
Is it
Sorry.
Beth?
No, it's Peter Murphy that's presenting this item. So I don't know if he's on the call.
Who's that? Neil?
No, Peter Murphy.
No, it's Peter. He's on the call, Chairman. He's on the call.
Right. Peter?
We can't hear you very well, Peter, or at all, in fact.
No.
Chair, might I suggest that we perhaps suggest Peter tries to exit and re-enter the meeting, and we can perhaps move on to agenda item 5 while we try and work that out.
I'm Peter Murphy here. I don't know if you can hear anybody, but I'm also waiting for my colleague, Janet Barnes.
We could hear you then, Peter. Can you hear us?
To join. She's stuck in traffic.
Right. So do you want us to hold this and we'll go on to agenda item 5 and then we can come back to it? Would that be helpful?
I think Peter's just exited the meeting, so I think that's the course of action we should take, Chair.
Right. Okay then. Right. That means I've got to skip everything. Right. Agenda item 5 is Blackpool CCG end of year report. Is that going to be you to start off, Roy?
Kate's going to be presenting this on behalf of the CCG.
Right. Okay,
yeah. Good evening, everyone. As instructed, I will just give you a very brief overview of the paper because I'm sure you've had the chance to read it. It is a high-level summary of Blackpool CCG and Blackpool Teaching Hospital's performance in 2020-21 compared to performance in 2019-2020. Within the report, what we've tried to do is give you a high-level summary of where the position is and also what we are trying to do to improve positions if that's appropriate on behalf of the Fylde Coast and also at an ICS integrated care system level, which is across Lancashire and South Cumbria. So if you'd like to ask any questions, I'm sure myself and my colleagues would love to be able to answer those for you in the best way we can.
Okay, thank you for that. Right. Do members have any questions on the report? No? Right. Councillor Scott, Michelle Scott.
Sorry, Chair, struggle to unmute then.
Yeah.
Yes, the cancer waiting times generally are reasonably positive, I suppose, but with the obvious exception of breast cancer. And in the report, we're told that this is largely down to radiology capacity and that it's hoped the target should be achieved by June 2021. We've now passed June 2021. So how confident were you of those targets being reached, and have they been reached?
Before I pass over to my colleagues from the Trust, I'm hoping Pete Murphy has come back on, because he'll be able to give you a much more detailed, up-to-date position than I am. It isn't a breast cancer target, it's a breast symptomatic target. So it isn't, if somebody is referred through on a cancer pathway and the GP thinks that they have breast cancer, then they would automatically put them onto the 2-week wait pathway. I'm sure Neil will be able to clarify that further, but it's a breast symptomatic, which is different from the GP thinking that they almost certainly have breast cancer. We haven't got the June data yet. I'm sure Pete will be able to give you, like I say, the up-to-date position. I listen into the weekly meetings, and I know that that situation is improving. It was definitely a blip, and they have definitely employed a long-term locum, which is going to help the situation. Pete, are you there to add any detail to that? Have you come back in?
Can you hear me?
Yes.
Yes, there it is. Thank you.
Sorry, I've missed the start of the call. I'm waiting for one of my colleagues, actually, Janet Barsley, to join me for the breast section of this. But I missed the presentation. I'm not sure what's been covered, so forgive me for that. But I wasn't in the meeting.
Yeah, that's okay. I think, Kate, you've kind of answered the question, but I'd just like to point out, really,
can somebody turn? Somebody's got their mic on. Could we make sure that if you're not actually speaking, that you mute yourselves, because otherwise we're getting a lot of feedback. Thank you. Right.
All I wanted to say, Chair, if I may, on following on from the reply, is that from a patient's perspective, it's extremely worrying, and therefore we would need to see these targets met and sustained, really, because any sort of worry with regard to symptoms is of concern to patients and causes other symptoms. So, it's good to see that you hope you've got on track, and I hope that you can report to us very soon exactly what the position is and that can be sustained. So thank you for your reply.
Would it be possible for the June figures to be sent to Sharon as soon as they're available, so that they can then be circulated to members of the committee?
Absolutely, not a problem. I'll work with the Trust to see the most up-to-date position they can give us. It's difficult with cancer to be validated, and that takes time. Next week, I will definitely have the validated May position, and by all means, I will send it through to Sharon, yes.
Okay, thank you. Right. Any further questions on that report?
Yes, please.
Right. I've got Councillor Mrs. Callow.
Thank you, Chair. I wondered if somebody could give me a definition of medically fit for discharge. What exactly is that? Excuse me. And further on this, I'm on page 23. At peak times, after you've had meetings, supports patients being discharged quickly to care homes. I'm sorry if I speak now from personal experience, but when my husband was in Victoria Hospital with coronavirus, on the Saturday we were told he was medically fit for discharge and he would be sent to a care home. That was the Saturday, and he died on the Tuesday. We did object to this and he wasn't discharged. But this bothers me. What do you mean by medically fit for discharge and then quickly sent to care homes? We know what happened a few months ago with that, and this report does concern me greatly.
Okay, thank you. Thank you, Mrs. Callow. Does somebody want to reply to that one directly?
I can certainly help with the medically fit for discharge. I can't talk specifically about that case, but please may I offer my sincere condolences. That's the first thing I wish to say.
Right. I think we just need.
But medically fit for discharge is when a.
I'm sorry, Chairman, I'm not catching this response, and it's very important.
It's Peter, you're breaking up and you've just gone completely.
I want to know the definition of medically fit for discharge.
Can you hear me now? Is that better?
Yeah. Okay, Maxine. Let Mr. Murphy reply.
Medically fit for discharge is when a... Yeah, I can hear you. Sorry. If I'll try and provide an explanation. Medically fit for discharge is when a...
You must know the explanation. I want that, not just on my personal behalf, but on behalf of the people throughout this country who would like the definition of medically fit for discharge and then being sent to rest homes.
Okay, Maxine, right. Now, Peter, can you give us that definition, please?
Yes, I can. Can you hear me?
Yes. Carry on.
Medically fit for discharge is when a member of the medical team has made a clinical assessment of the patient, and through that clinical assessment it has decided that there is nothing more from a medical point of view that patient actually needs in terms of care provision.
Unbelievable. I'm sorry, Chairman, but it's unbelievable, and I'm not satisfied with that explanation. There are vulnerable people out there in this country that rely on the medical profession.
Okay. Yes. So I appreciate that sentiment, but what that means is that through that spell in hospital, that care episode has been complete. That doesn't mean to say that they're discharged from their GP or anything else like that. That means that actually, from a hospital perspective, that's as much as the hospital can provide in terms of ongoing medical treatment. But there are other district nurses or GPs or so on and so forth could take that care on.
Okay, right. Councillor Hunter.
Sorry, I had a job on muting myself then, Chair. Actually, my question, I've got a second question actually, and it really just follows up on the point that Councillor Callow has raised in that. In making that medical assessment regarding as to whether a person is fit for discharge or not, would it just be the assessment of one doctor, specialist or whatever, or would that assessment be sort of like, what's the word for it? Would it be quality produced by being run past another medical professional, i.e. would two doctors have to agree it? In case the first doctor, I'm afraid, got it wrong, what would that be the case? That's the question. The second point is more general. It's not to do with the end of year report, and it's just really, do you envisage any problems in the future with the possible merger of several CCVs across North Lancashire and possibly Cumbria? Okay, thank you.
Okay, right. Who wants to take those two questions on?
Well, I'll address the first question, which is, do you need two doctors?
Right.
We don't need two doctors to make that decision. A clinical professional in their own right would be able to make that decision autonomously. If that was challenged, then of course people can ask for a second opinion. But ordinarily, that wouldn't be the case. A consultant, for example, would have the necessary qualifications as to a registrar to be able to discharge a patient from care.
Okay, right. Thank you. Right, who wants to deal with this?
I was just going to add, is it worth adding to that, Peter, that those decisions are generally taken after the multidisciplinary team, which would include physios and other allied health professionals, would also input on that discharge decision? So the consultant making the decision would also take into account the opinions of other health professionals involved in the care.
Yeah, yes, of course it can be the MDT, but of course, a registrar come to see me as a patient will be able to discharge me as well. So yeah, it's a combination of both, Neil. That's correct. Thank you.
Right, thank you. Right, who wants to deal with Councillor Hunter's second point, which is the mergers?
If I start, Chairman, if that's okay, and perhaps,
yes, carry on.
Perhaps Neil could come in and help me on that one. First of all, Councillor Hunter, I think the committee will be aware that this is all subject to legislation. That legislation has not yet gone through Parliament. We're expecting the legislation to go through probably in July, towards the end of July, the second reading of the bill. But your question refers to, obviously, is the CCGs coming together as a single unit at ICS level, in other words, a Lancashire and South Cumbria level, where there will be, and there is at the present time, a shadow strategic commissioning committee. Now that does what it says basically. It's about strategic issues that are being dealt with at Lancashire and South Cumbria level. However, I think again, all your colleagues will know that we are currently working towards an ICP, which is also subject to the legislation as well. The ICP covers the whole of the Fylde coast, and the basis that the ICP will work on is the process of subsidiarity, which is the work that should be done at local level will be done at local level. In other words, if we are required to take any actions on behalf of the health service, that will be done at that locality level through the ICP. We already have in place an interim ICP team. Neil Hartley-Smith, who is the interim director for that team, is on the call this evening. So it's important, I think, to recognise, firstly, that we're not entirely sure when the legislation will go through and what that will include, but we're working on the basis that that will include an ICS at that Lancashire and South Cumbria level, which will work on the strategic objectives for the whole of Lancashire and South Cumbria, and we will have an ICP at Fylde Coast level, which will take on the locality responsibilities for those commissioning decisions. Neil, did you want to add anything to that?
Yeah, I think, thank you, Roy, and good evening. I was just saying good evening before, councillors. Yeah, the CCG, as you're alluding to, will cease to exist as a statutory body at the end of this year, so the end of March 2022. And at that point, the statutory body involving commissioning health services, that will pass over to the ICS, which will be the Pan-Lancashire South Cumbria organisation, which will commission healthcare at scale. This will take care of the bigger items, such as commission hospitals, provide care, etc. However, there will be provision by the ICS to provide decisions made at a local basis, and that will involve the ICP, which is the Integrated Care Partnership. The Integrated Care Partnership takes account of our acute trust, our primary care, social care, mental health, voluntary and faith sector providers, etc., and tries to deliver or will deliver health for the local community, which is relevant to the local community. But it goes much further than that. This is not just about providing health care for people. It's more about trying to keep people in good health. So this is looking at how do we stop people becoming unwell. And we're about to get involved in quite an ambitious stakeholder information collection. We're going to try and get this as wide, as broad as possible. So we're going to be looking at, we're going to start our questions with school children. What should healthcare look like? And we're going to take that all the way through to people in care homes, people with learning disabilities, just about everybody we can get hold of, particularly in hard to reach groups. We want to listen to what their thoughts are on what health is about and what healthcare should be provided and what that should look like. We want to reinvigorate the communities to be involved in their own health and improving their own health. And so in terms of the leadership group we have at the moment, the chair of the ICP is a chap called Stephen Fogg, who's recently become the chair at Blackpool Teaching Hospitals. Stephen's background is he was a director with BAE Systems, And I think he spent most of his working life with them, starting as an apprentice and worked all the way through to senior director level. From the executive director point of view, I will be running that role, trying to keep things in order. And we have an excellent council employee who's working with us by the name of Pauline Wigglesworth. The name may be familiar to some of you. She's been involved in the Sure Start lottery funded initiative, which has been running locally quite successfully. And myself and Pauline have regular meetings to try and decide how are we going to push this agenda forward. Stephen is really invigorating the things from the acute trust. So we're quite confident, to answer the question, Councillor, that when April next year comes, that we will have a partnership in place to provide healthcare and improve health at locality, that being Blackpool, Fylde and Wyre, which will start to, as I say, not just look at the problems people go into hospital with or go to their GPs with, but improve the health, looking at the population health, the things that Arif often speaks to us on these meetings about. So yeah, I would like to reassure colleagues on the call that, that this is very much in hand, and hopefully we'll be able to provide a presentation later in the year. In fact, I think Councillor Hutton has invited us to give something later in the year on the ICP developments, if I'm not mistaken. Thank you.
Yeah, you're right, Neil. We would like at the September meeting a detailed update on where we are with it, because obviously this has got ramifications for all of the residents on the Fylde coast. So we need to be aware of what is going to happen, so that when we get the questions as councillors, we can, at least deal with them competently. So yeah, we've said September, and hopefully if we've got the government to get their finger out and get it sorted, then we should have that information. Okay, is everybody, all the councillors, happy with that we get the report in September? Everybody, right? Jolly good. Thank you very much. Any other questions regarding this item?
Yeah, Chairman. Thank you, Chairman.
Yeah, Maxine, carry on.
Thank you. Thank you.
Sorry.
Yes, I look forward to seeing this report in September. But this report here, I've just got to say, I found very depressing reading. I know the NHS has had a difficult time at the moment, but let's hope that now we have got a new health minister and he can concentrate on the job in hand, then perhaps things will improve for the health service for the good of the nation. Thank you, Chairman.
Okay, thank you for that. Anybody else? Councillor, Mrs. Scott.
Sorry, Chair, if I may, I think Councillor Coleman's been waiting for longer than I have.
I'm sorry, but I can only see a number and I've just come over. Right, okay then, Councillor Coleman first then.
Thanks, Chair. It's just the abbreviations on the list. Is there any chance we could have a link or something to say what they are? We know what they are, but the lay members or, the people out there will not have a clue what some of these abbreviations are. It's like what is it? UHMB. What I don't know what that means.
Sorry, it's University Hospital of Morecambe Bay. Absolutely. What I'll make sure I do is send through a glossary of abbreviations separately next time. Apologies.
Thank you. Or even just put it at the bottom, because like I say, we know what the ones above are, but people reading this haven't got a clue.
I'll make sure that's done for next time.
Thank you so much.
Thank you. Right, we then come back to Councillor Mrs. Scott.
Thank you, Chair. On page 28, where we're looking at the mental health, dementia and the IACT results or report, there's quite a lot of greens on that page, which at first glance looks encouraging, but when you look at the targets, some of them are very low, some of them are quite low. So I wonder, are those targets robust enough? It's great to see green boxes, but when we're looking at the dementia, for example, 66.7%, is that robust enough? Would we want to see it higher? I think we perhaps might. Could we have some explanation around those targets, please?
Does somebody want to come back in and answer that question?
From my understanding, those targets were set from the national basis, were they not, Beth?
Yes, they are. Yeah, absolutely. I was just going to say that. So they are nationally mandated targets. Of course, all of these things will be refreshed and reviewed, and normally they're reviewed on an annual basis. But obviously, with COVID, we've kind of rolled over targets. So that's been a national decision to roll over those targets.
Okay, thanks, Beth. All I would say is that there's nothing to stop us perhaps stretching those targets for our locality if they're national minimum targets.
There isn't, and obviously we always aim to kind of exceed targets. We don't see them as a ceiling. However, you know, with the situation as it is, we found that quite difficult to exceed some of those targets. But obviously, we would always strive to do that. One of the things that I was just going to add, Councillor Scott, is that we do have an opportunity on an annual basis to feed into NHS England. So there is an engagement process, so we can feed these comments in through the engagement process in terms of what those targets might be. So we will do that. We'll make a note of that.
Thank you.
Thank
so
you.
could I just make a further comment? I think it's right that Councillor Scott does challenge and push us on this, and of course we want to make sure that no person with dementia goes undiagnosed. But I think we must take into account the fact that we are looking at a set of figures here which are skewed somewhat by the fact we have just moved through one of the biggest health disasters that anybody will probably face in a lifetime. And this is the numbers we are seeing here are representative of a service working in completely analogous ways to what it is used to working in, trying to give new ways of consulting to make sure we can still contact people whilst seeing people in socially distanced ways, trying to deal with people who can't be seen in hospitals because their clinics are having to socially distance. So I think it's really important that we understand that the figures we are seeing at this annual report are reflective of best efforts through the middle of a pandemic. And I can't underestimate being on that front line, how difficult it has been at times to try and address even the emergency stuff. And I'm sure Peter will have found this with colleagues at the hospital, that it has thrown at us challenges which we never thought we would have to face. And the NHS has, to a large part, stood up and faced those challenges. We have, whilst continuing to try and meet these targets, set up a vaccination scheme which has delivered remarkable results in Blackpool. We have been fortunate in Blackpool that our COVID rates have not been as high as places such as in East Lancashire. But I don't think we should lose sight of the fact that whilst we are looking at these figures, we must also understand that this is happening all over the country, and similar results will be being played out to similar scrutiny committees up and down the land. And I have looked at some of the council figures and compared it with our local neighbours, such as Morecambe Bay and East Lancashire, and I must say that Foul Coast and Blackpool do show quite favourably when compared with their neighbours. Thanks.
If I may add, just to I think support that. I mean, we have been through the most extraordinary of times, and of course, some of the targets that were set out have been set out from an historic point of view way before the pandemic actually hit us. And in all honesty, and this is the reality of where we've been. Well, I've never known anything like it. There's been no rule book for this pandemic. We've literally been faced on a daily basis with having to make decisions where there's been no policy, there's been no standard operating procedure. We've just had to, through our professional judgment views and collectively together, and we have worked collectively together, come together to do the best that we possibly can for our patients. And indeed, some of the data that we're now starting to see for the first time in a long time, certainly from a hospital provider perspective, is that we are starting to see performance at some of the best in the country, actually. So and so I think that some of the conversation here today needs to be seen in that light, notwithstanding the personal tragedies and all the rest of it that has occurred through the pandemic. It has been the most truly difficult of times for the country. healthcare has been, I guess, at the centre of the storm in some of that.
May I just respond? Yeah, thank you. On behalf of the committee and certainly all the residents in our ward, and I'm sure across the whole of Blackpool, we absolutely understand the great work that's been done by the NHS and partners during the pandemic. It was unprecedented. Everybody's pulled together, but inevitably patients have suffered, and that's not down to you. It's not down to us. It's not down to them. It's the situation, and for them, getting back to where they need to be in terms of having their health, their health conditions cared for in the way that they need to, has to be a priority going forward as we come out of this situation. And yeah, absolutely fantastic results on the vaccination programme, and nobody's doubting that. But we can't take our eye off the ball now. We need to make sure that we're moving forward at pace, and that was the spirit in which my question was raised. So thank you.
Appreciated. Thank you.
I know that we can be critical of the NHS, but we do, and as Councillor Scott says, we do appreciate everything that's been done by the NHS. We're not having a go, and we fully appreciate the strain and the stress that the medical profession have been under over the last 18 months, and probably at least for the rest of this year. So, you know, we do thank you for what you've done, but we do need to now be looking at getting back onto some sort of an even keel, so that those people that have been waiting and are suffering at the moment are reassured that they are being looked at, and that they will be called in for whatever the treatment they need as soon as possible. Okay, right, thank you very much for that. Are there any other questions on agenda item 5?
Can I come back in, Chair?
Yeah, sorry, Councillor Coleman, carry on.
Yeah. Can I just ask, on all the data, there's nothing in there about people being discharged and waiting for prescriptions. Is there any data there that we can look at? Because I know people are still waiting 6 or 7 hours for a prescription, and it's just, people are just in beds waiting for prescriptions. Is there any data saying how long people are waiting, or is that not available?
That would probably be best answered by Peter and the discharge teams. I know from the conversations I do have, I know that it is in the interest of the hospital and one of the paramount goals of the hospital to get people discharged in a timely manner, because that frees up bed space in the hospital to move people from the A&E department into beds. So I would have thought that would be one of the processes which needs to be as expedient as possible, but I'm not aware that I've seen any data which tells me the average time for a prescription to be delivered to a patient.
I think the question, isn't it? I think the question is about the patients that have been discharged. Is that the question?
No, it's the
length. You're waiting for medication.
It's the length of time between being told that they're being discharged, waiting for prescriptions, and then actually leaving. And I know from personal experience, from family experiences, that can be very frustrating, that you're sitting there, you're told you're fit to go home, but you've got to wait for a prescription. And it can be, you know, hours, because somebody needs to sign a bit of paper or something. And it is very frustrating. So I think that's something that, again, we'd like some information on, so that we can be reassured that the waiting times between being told that you're going home to the actual time that you, excuse the expression, but actually get kicked out, waiting for a prescription, is reduced.
Thank you, Councillor Hutton, and we're happy to bring some data back with regards to that to the next meeting, if that's okay with you. Okay,
is that all right with the rest of the committee?
Thanks, Chair, that's fine.
Okay, thank you, Councillor Coleman. Right, are there any more questions from members of the committee on agenda item 5? If not, can we go back to agenda item 4, which is the avoidable readmissions?
Sure, I can take that. I was hoping my colleague was going to join me to share this presentation, but I think there's been some accident on the M55 and M6, and that's holding people up getting home. I'm still in the office. So if I quickly take you through the slide deck, would that be helpful?
Yes, please. Okay,
so the first slide you can see in your pack is a slide that's entitled "Readmitted Patients Occupied Almost 20% of Occupied Beds in March 2021." What I would say is that this business, as you can see through the slide deck, is actually quite a complicated business in terms of readmission, and for all sorts of different reasons, patients will be readmitted into the trust. But at the data set, as was described here, 140 beds, 90% of the total occupied beds in March 21 were occupied by readmissions through non-elective admissions of patients who had been previously discharged within the 30-day spell, and that's a national measurement. So that means that you've come in through an emergency pathway, you've gone home, and you've been readmitted within that 30-day spell. And you can see that graph there that sits around that basically shows some variation to the right, and you can see through the data sets of around when the pandemic started, actually, that we saw a reduction in the number of patients that were being readmitted. So I hope everybody can see that. I'm going to go on to the next slide, if that's okay. I'm happy to take questions at the end. When we compare ourselves to the rest of the integrated care system, you can see here that Blackpool Teaching Hospitals has got the lowest rate of readmission. So that's an important thing to say, that when we compare ourselves to other NHS organisations, that we've got one of the lowest rates. And there is some variation sat within the graph, but actually, when you look at it in totality, we've got one of the lowest rates across the ICS. Take you to the next slide, and this is where it starts to get a little bit more complex in the way in which we look at it. When we looked at the analysis over the last year, 16% of the 30-day readmissions to Blackpool Teaching Hospital had the initial admission at a different healthcare provider. So I'm Peter Murphy, and I've gone in with my condition at Royal Preston Hospital. Even though I represent to Blackpool Teaching Hospital, I'm still regarded as a readmission. Does that make sense? So it's not comparing us Blackpool to Blackpool. It's more complicated than that. But the remainder, the other 84% of the totality of this analysis are Blackpool Teaching Hospitals to Blackpool Teaching Hospitals. When we look at readmission rates by point of delivery of an initial admission, this graph is telling us that we can see 12% of the 30,000 non-elective discharges in 2020 were admitted within 30 days. So that's just a pure mathematical analysis of what it is. And you can see there through the graphs that you can see the breakdown. And clearly the non-admitted rate is by far the highest numbers of patients that are readmitted. And that would make some sense to us, of course, because elective patients are generally planned through a pathway type of event, and you wouldn't expect to see many of those types of patients admitted. But here's where it gets even more complex, because we're also talking about the human body. So we're not just talking about I'm Peter Murphy and I've come into Blackpool Teaching Hospital with a cardiac condition, and then it's not necessarily to be assumed that if I'm readmitted, it's with that same condition. So you can see here we've given an example and broken down, and this is to do with endocrinology. But that means that what this data is telling us is that only 16% of the readmissions were back to endocrinology. I came in with another reason that needed to be looked at and cared for within a hospital-based setting. So again, that's further complicated. So we can measure me, and I might be in one hospital and then another hospital, I'm still sat within that data set. And of course, then because of our body and the complexity of our bodies and our organ systems, I could come in with one particular part of my body that needs to be cared for and attended to and diagnosed or whatever. And then sometime later in that 30-day spell, still come in with a different condition, with a different part of my body, but that's still classified as a readmission. So in summary, it's a complex picture. What we are doing is we at divisional level, there are detailed reviews of readmissions around themes and trends and things that we can do to prevent readmissions from occurring. But it is a very complex picture that we are dealing with in terms of the overarching rates of readmission, and that's what that slide set is demonstrating to us. So thank you. I'm happy to take any questions.
Thank you. Councillor Mrs. Scott.
Thank you, Chair. Looking at the last page of the presentation, Peter, it's explained about exactly what you've just said, that a lot of the readmissions are for different reasons.
Yeah.
I was going to ask about paediatrics, but I know you put a note at the bottom to say that paediatric care is always classed as paediatrics, so they could be coming back for a different reason to that which they were discharged. So I won't apply my question to that unless it does apply.
Sure.
And I get your confirmation later. But urology, 11%, is quite a high readmission rate compared to any of the others. So might this be due to people being discharged inappropriately or too early perhaps, or inadequate post-discharge care or treatment, or is there likely to be some other reason for repeat readmission to urology in particular?
Well, I mean, there's all sorts of different reasons why that could be the case, and all that you've described could be the case indeed. And we try to learn through readmission analysis to make sure that we give the right discharge information. Now, whether somebody follows that information is a separate issue altogether. And of course, with sometimes with urology-based cases as well, you can get blockages in catheters, for example, that will need to be re-examined and re-looked at, and that could be a representation just purely back to ED for a reblock catheter. So, if you take all these different subsets in terms of case mix, you could apply any sort of logical reason as to why some people may or may not be may come into the hospital, back into the hospital and represent with regards to that. But I suppose that the key information here is that as an organisation, we continue to analyse the readmissions, and we continue to try and learn from readmissions to make sure that we do all that we can to give people the right information and try to keep them out of hospital. You know, frankly, it's awful for patients to have to come back in, and nobody wants that. We certainly want it for ourselves, but you know, it's also frankly not great for the hospital as well, because it just puts extra pressure into the system, if you like. So, you know, at a very practical level, it's on our own self-interest to do as much as we can do to understand and do as much as we can to learn from these readmission patterns, and we do that for all conditions. It's part and parcel of the way in which the different departments operate.
Okay, so now, given that these figures have now been published, is there a chance that might be looked at, you know, seeing as it does stand out on that chart as being unusual and high?
Yeah, we certainly, well, we can come back and give a breakdown of urology if you'd like us to. But I think the assurance that I want to give is that every department across there is looking and trying to make sure that its discharge rates readmission rates are as low as possible.
Thank you.
Okay. Did you want, Councillor Scott, a detailed breakdown of that particular one, urology?
I think it might be helpful because it is quite a lot higher than the others, and it does stand out on that chart. So I think that might be helpful, just so that, to help us understand really why that one is so significantly different. Thank you.
It'd be a good example. Could you arrange for that to be done, Peter, for the
yeah, certainly if we take it through the minutes. Yeah,
okay.
If we take it in the minutes, I'm sure there's a note to that effect.
Right. Okay, thank you. Are there any further questions on the readmission? Councillor Danny Scott.
Yes, thank you, Chair. Yeah, just carrying on a similar theme. There's lots of graphs here and indications of why they're coming back in. Is there anywhere that's been recorded as to the main reasons of admin errors that take place as to why patients are readmitted? I know that there's mistakes been made over medication, either the wrong medication or insufficient medication. For instance, I know someone who had 3 different types of medication and they only had 2 and they were readmitted again within 2 weeks. Is there any indication or any graphs, any information about why patients return? Thank you.
We have some generic breakdown to respond to that question. We have some generic breakdown about why people are readmitted, and when we see events the way that you've just described, Councillor, we would incident report that. So we would put that into our instant reporting system, and what that means is that there's therefore an investigation undertaken, and then we can learn lessons as to how we can work towards prevention of that happening again within the trust. And that's an established system. If you look at the trust database, we would probably input at least 15,000 incidents a year, not related to readmissions, but a whole gamut of things, because we want to be a learning organisation, and indeed our data is really encouraging that space, because we're reporting more and more incidents, so we can become a more open and transparent and learning organisation.
Okay.
Thank you.
Any further questions? Councillor O'Hara.
Yeah, a couple of things. Can we have a more of an explanation where it says that a different healthcare provider has discharged them? Is that because they had a particular reason for being in a different healthcare provider, or is it where they're located and they live? And secondly, how much has COVID added to these charts? Because hopefully next year they won't have been COVID, so there might be a different set of charts.
I mean, the answer to the first question, there can be various reasons as why you end up in a hospital. So, for example, in Lancashire and South Cumbria, if you needed some treatment, for example, for your heart, you would come here because we are the Lancashire Heart Centre. But if you needed some treatment then for your brain, you may go to Preston. So there are different specialties where they're only operated in the main out of one hospital. So that means one reason. And of course, you could become ill with visiting your family, for example, and be admitted into the local hospital there, be discharged, come back home again, and then readmitted back into Blackpool. So there'll be a gamut of reasons as to why those issues exist. But I suppose the other question that you've asked us, and if you look at the data is suggesting that readmission rates have dropped during COVID. So when you look at that graph, you can see that there is a kind of like over a timeline up to COVID, there is kind of like just normal patterns of readmission over a time period, and then it seems to drop away, which you would expect because so many people didn't come to hospital for all sorts of different reasons during the pandemic. And I think what we will see is then we will likely see some natural progression back to, especially as more of society opens up, where we will see that graph perhaps even go back to previous levels. And of course, our commitment is that we will continue to work diligently to understand the root causation of readmissions and do all that we can to prevent them. But I have to say to the committee, we will never eradicate readmissions. They're all part and parcel of the way in which the human body works, frankly. They will always exist.
Okay.
Thank you for that.
Thank you. Right, are there any further questions? I'm not seeing any hands. Is everybody happy with that? Then can we move on to, we dealt with agenda item 5. We then come on to agenda item 6, when I can get me finger working a bit faster.
Chairman, may I just come in at this point?
Yes.
Thanks, Chairman. It's normally on this meeting when the colleagues, the clinical commissioning group, finish their item, they would leave the meeting.
Right.
I'm just asking yours and the committee's permission if it's okay for the CCG colleagues to leave the meeting at this point.
Yeah. Yes. Sorry. By all means, if you want to leave the meeting, then please do so.
Okay. Thank you for that.
Okay. Sorry about that.
No, that's fine, Chairman. That's fine. That's. Thank you very much for your help, and thanks to you and colleagues for your questions tonight. And we look forward to seeing you as soon as possible in the near future, I should say. Okay.
Thank you for all of your inputs. Thank you.
Thanks again, Chairman.
Right. Okay. We now come on to agenda item 6, Blackpool Teaching Hospital NHS Foundation Trust progress update. Who's taking this one? You again, Peter?
It's me. They've all left me. I'm by myself. Be gentle with me. Right. So I'm happy to take you through the paper. I'll take the paper as read, if that's okay.
Yeah.
It gives the paper in itself gives a breakdown of some of the work that we've got up to through the pandemic. One of the things that I want to say to the committee is that we have been very, very focused on dealing with an extraordinary, as has already been alluded to, pandemic, and we've had to deal with that like every other healthcare system has. But as we've talked about through this committee, we've also had to commit to improvements across the trust, because those issues existed before the COVID pandemic hit. And what I want to share with the committee is that we have worked incredibly hard, and the teams have worked incredibly hard to make sure that we don't just deal with the pandemic and stop doing some of the other improvement work that we knew we had to do to get the services right and better for patients. So I think that's one of the key messages that I wanted to share with you. A couple of things just to call out, if that's okay. We've made tremendous progress around the CQC inspection, must-dos and should-dos. So we've been working and tracking all of the must-dos and should-dos. And as you can see through the paper, an extraordinary amount of hard work and diligence has been undertaken to get those to the level of completion in spite of a national pandemic. And I think some of that was actually borne out when the CQC inspected us in January of this year, where in essence there were a handful of must-dos and should-dos, and nothing that they came to tell us was there was no surprises for us. Even where the things were things that they observed that they thought we should do differently, as in the Care Quality Commission, we already had work ongoing, and we're undertaking work to improve within that space. And I think that's one of, if I may share, that's one of the acid tests of any organisation, and it's to have no surprises through an inspection. No trust is ever going to be 100% perfect, but our challenge is to make sure that we are aware of all our issues and we're working diligently through them. For the first time ever, the trust is able to report. Colleagues will be aware that for many years, our mortality data has made us as a national outlier. So that means that there have been more deaths occur at Blackpool Teaching Hospitals than you would ordinarily predict it to have had through the way in which we measure. And for the first time ever, the trust is now starting to see historically low levels of mortality, and those levels are now at national averages. There's more work to do, because we think we can continue to improve in that space. But I think if I recall the first ever committee I came to, there was a very long conversation around mortality, and a significant frustration from the committee around when will this ever shift. And we are seeing that data moving in the right direction now, and there is more work to do in that space, and we know what we need to do, and we're getting on with it. So I think there's some really encouraging data set within this paper in spite of the pandemic, that shows that that services are getting safer for patients. One of the things that I also want to draw your attention to is one of the systems that is associated with an organisation that's got good high standards is something called an accreditation system. This is a series of very exacting standards that we apply to all wards and departments that are objectively measured by an independent team on a regular basis. These types of systems have been around for many, many years, but nonetheless, we've launched one in Blackpool in the eye of the pandemic, frankly, in January 2021. And to date, the team that we've employed, who are a team of nurses, who we have employed to undertake those assessments, have pretty much done the totality of the Victoria site. There's more work to do in community services. There's more work to do in outpatients departments for the bed base of the Victoria site. That every single ward and department has now been assessed, bar one or two. And I have to say that it's been tremendously well received within the trust. And I've been absolutely delighted the response from the staff. And we can see, and in fact, I've just taken some national dignitaries around the trust, and you quite clearly can see a tangible difference in the way in which those wards and departments are now organised. They are well structured. There is far less chaos with it, even though we've got quite limited accommodation, hospital accommodation. Some of it is quite old and difficult to manage. It's in a far better place than last year. So continuous improvement and an incredibly important development within our trust with regards to the way in which we operate and understand all of the different key lines of inquiry, all the different measurements, all the different standards that need to be applied to healthcare. This is a programme that will never go away. I believe that it will stay and exist in the trust for many, many years to come. It's not my programme. I'm the director of nursing that introduced it, but it's owned by the staff, most importantly, and it will stay with them through different iterations for many, many years to come. So that's something that I wanted to just call out. There's a considerable amount of other additional information in there. That there's been a tranche of appointments that we've made, and for the first time ever, we've got a dementia and disability lead nursing post, and there's an action plan with a defined strategy for around those vulnerable groups. What else did I want to call out to you? And then finally, I guess the final thing to say is that the trust is the board of directors, and again, we've had a board of directors meeting today, has the last 5-year strategy came to its natural end during the pandemic. The board sat and produced a 1-year strategy, which is around no waste, no weights, and no harms, to bridge a gap for a year. And we are currently developing the next 5-year Blackpool Teaching Hospital strategic document, so that annual plans about the way in which we manage our business will then fall from that strategic document. So there's some work in place, and that will be launched, formally launched in the organisation for the next financial year. So in conclusion, it's been an extraordinary year, as you can tell, but we've not sat back on our laurels, and we've continued to work diligently to make sure that we design systems and processes for the trust that not about us as individuals, but that actually will stand the test of time and will help us to become a much more reliable deliverer of healthcare. I'll leave it there, and I'm more than happy to take any questions on the paper.
Okay, thank you. I'm going to start off. You've managed to deal with 110 out of 111 musts, and there's, I think, 9 shoulds. Can you give us a brief description of what that 1 and the 9 are that haven't been met so far?
Yes, I can. Yes, it is. Yeah, and these are all works in progress. The must was a re-enablement of a room in ED for ligature-free points, and that's been difficult from a building and tech point of view, if you like. That makes sense.
Yeah.
And there are a handful of should-dos that are elements of work that are in essence iterations. So we continue to. The way in which we've done it is that we won't sign anything off until myself and the medical director are absolutely assured with data that they have been completed. And we haven't yet had the totality. So they're all at green, but we've established. So if you think about it, red is nothing's been done. Amber is works in progress. Green has been, it's completed. We've introduced a section called blue. And that blue section is where I want to see data, because I don't want people to tell me that it's better or complete. They need to show me to. And so those 9 are sat within that. And I don't have the specifics to hand, but I will find that information and get that to you.
Thank you very much.
The must is certainly around the ligature-free cube.
Yeah, don't get me wrong. I think it's really very creditable, that the number that you have dealt with in very difficult times. But obviously, it's always those that haven't been done are now the most important, if you understand me.
Of course.
Thank you for that. Councillor, I'm not sure who had their hand up first. So I'll go to Councillor Critchley first.
Thanks, Chair. This is my first committee this for a while, so I hope this one's not a bit silly, but can you just explain to me what the emergency village, it says that the must will be completed when work on the emergency village progresses to completion. Yeah. And then, sorry, I've just got 2 more. If I say them all at once, and then you can, and then what do course measure and what are the care indicators? Thank you.
So the emergency village is a new build, and that will give us additional emergency department capacity. We've got one of the smallest emergency departments in the country. So there's a big enablement scheme that's going on that will build us some more emergency department capacity, but it will also build us some more clinical assessment capacity as well, because again, we've not got enough clinical assessment beds. And as that work is going through, as you can imagine, there's a whole load of capital bills within those new rooms that will be completed. There's over 160 different care standards within the COAST system. So there's a lot of them, yeah, over 160. It's a very, very exacting and deliberately designed system, because these are all the things that are really, really important. So it will come as no surprise. Some of it's around cleanliness, some of it's around documentation, some of it's around medication safety, some of it's around patient identification, some of it's around patient experience and feedback. And all these things then amalgamate into a series of assessments. And we through observations that are independent, that team then through a grid of the way that we work it, assigns each one of those standards to either a bronze, silver, or gold. And then there's a kind of like a measuring up, totaling up scheme at the end of it. And then each ward and department is then assessed as to whether it's gold, whether it's silver, or whether it's bronze. And then we portray reassessments of those based on whether, for example, we will go back and reassess a bronze area after 2 months, but they've got to be a completed action plan. Does that make sense? So it's an incredibly detailed programme.
It does, but does that extra pressure then on the staff take away from the caring? Like, because to me it sounds an awful lot of extra work. I agree it needs to be done, but I just wondered about the extra pressures on the staff.
No, because it's what they should be doing. It's measuring what you would want for yourself. It's measuring what I would want for myself and my family. So it's not, it's a different way of working, and it's a different set of accountabilities. But I don't apologise for that. That's the right thing, because it's what the care that I would want for my loved one. It was the environment that I would want my loved one to be cared for. So no. And the independent assessment, we've been able to form a brand new team of brand new people. So that's an independent group. They don't deliver care in wards and departments. They make the assessments, supported by other members of staff. It really is a system that's associated with either a good organisation or an outstanding organisation as rated by the CQC.
Okay, thanks very much for that. Thank you.
You're welcome.
Thank you, Councillor Chrisley. Councillor Mrs. Scott.
Chair. Firstly, congratulations to you for the achievement of 240 out of 249 of those actions. And I hope that we can look forward to hearing that those further 9 have been completed, very shortly, given that there has been a delay, and also whilst acknowledging what's already been clarified within this meeting, the fact that you've come through very, very challenging and unprecedented challenging times. My question really is around the, whilst we offer Kevin McGee our congratulations on his new appointment, it is a little disturbing perhaps that we have yet another change of personnel in that very high level within the organisation in what feels like quite a short period of time. So are you able, Pete, and I know you're kind of put on the spot here because we would always like the Chief Executive to be here, but can we have some update on what the position is with regard to appointments of someone else into that position, please, and when that's going to be and what the progress is to date? Thank you.
Yes, certainly can. So our new chairman, who's already been referred to in this meeting, Steve Fogg, has already undertaken, and we are currently out to advert. I can tell you the exact detail of that. So we're out to advert. I think the advert closes on Monday of this week. Can you hear me?
Yes.
All right, brilliant. You froze. Sorry, that's me. So the advert is going to close on this week, and interviews are scheduled for, I think it's a week on Tuesday, but I'll just tell you in a second. Yeah, Tuesday the 13th.
Okay, and you may not know the answer to this question because it's a bit up in the air, but previously, or most recently, we've had a chief executive that's been shared with other hospitals. Is it likely that that situation is going to occur again, or will we have our own dedicated person in that position?
It's our own dedicated chief executive.
Right, lovely. That's good to hear. Thank you very much for that.
Thank you. Are there any further questions?
What I would add is I think our chief executive has done some quite extraordinary things in terms of his leadership of our organisation, and I genuinely do mean that. And I think that the improvements that we've been able to make under his leadership shouldn't be underestimated.
I agree, and that's why I've raised it as a concern, because we really do want to see that positive moving forwards continue through this appointment.
So if I can give some more assurance that the chairman would has happily shared at the open part of the board today, that there is no doubt that the chief executive coming in will continue with the great work. This isn't about a stop and restart again. It's to continue what has already been undertaken over the last 2 years.
Thanks for that reassurance, Pete.
Are there any further questions?
Can I just come in, please, Chair?
Yeah, Councillor Coleman.
Thank you. And it's nothing to do with the reports. I'm sorry if it's not in the appropriate time, but I've been told that you can't get gluten-free menus at the hospital. Is this right or is it wrong? Thank you, Chair.
I would have to triple check that, but I believe that we will offer gluten-free menus.
It's just that somebody's been in and they haven't been offered anything and they've not eaten since they've been in the hospital. And I just wondered if you can just verify or let us know about it, please.
We certainly can. We'll provide that response.
Thank you so much. Thank you, Chair.
Thank you, Councillor Coleman. If you could do that and just let Sharon know what the answer is, and then she can circulate it to the committee. Okay.
Sure, Sharon. If you'll write to me and just let me know that question, I'll make sure it's formalised and we'll get it back to you.
Okay, Sharon. Right. Because obviously, if people are going into hospital with, and I would have I would have thought that they would get it because of the dietary requirements for people. But could we just have that confirmed? Are there any further questions? No? I'm going to get through it quick. Right. If there's no further questions on that, thank you very much.
Sorry, I think.
Oh, sorry?
Sorry.
Yes, sorry, I've just seen you again.
No,
Michelle,
that's okay. I just wanted to ask if we can formally follow up on those 9 outstanding actions and have a, you know, some sort of final report when those are completed.
Yes, we'll get that for the, should be a fairly brief report. So can we have that for the September meeting, please?
Chair, it's Dr. Hartley Smith here. Just in reply to the question on gluten-free diet, I am almost 100% that is available at Blackpool Teaching Hospital, because I do know that they also cater for halal, kosher, vegetarian, vegan, and gluten-free being a dietary requirement for certain health conditions. It would be, I think, unheard of for that not to be catered for at Blackpool Hospital. I'm sure the housekeepers on the wards will be more than happy to accommodate any requests of that nature.
Yeah, that's absolutely right. In fact, it's a shame really, because I'm actually booked in to go test the hospital food next week. So I could have given you the direct answer then, because I haven't checked through the menus. We as a group of board members actually have sampled the food to make sure that it's something that we would be satisfied with ourselves. So we can certainly furnish that answer, but I am 99.9% sure that we do offer gluten-free menus.
Okay, thank you very much. Are there any further questions? If not, thank you very much for all of your input. And again, we do appreciate the amount of work that's gone on over the last 12 to 18 months, both in the local healthcare and at the hospital. So thank you very much. And if you could pass that on to your colleagues, I'm sure that all the members of the committee would endorse that. Okay, so thank you very much. And if you want to leave the meeting now, then feel free. I think you've had a good grilling tonight. Thank you.
Cheers. Take care. Thank you very much. Take care, everybody.
Bye.
Bye. Thank you.
Look after yourselves. Bye-bye.
Bye. Right.
Adrian, are you clicking a pen?
Yeah, probably. Right. We then come on to agenda item 7. It's just, sorry about that. I was reading the top bit and thinking I'd missed something. The scrutiny work plan. Does anybody have anything they want to say on the scrutiny work plan? You've got the appendix, the work plan. We've dealt with the July meeting. We've got the September meeting, and this is going to be on the mental health and the drug-related death scrutiny review final report. Okay, so we've got those 2 for that, and we've also got the extra bits that should be coming back from this evening's meeting, just to fill in on that. We've got the October the 14th system flow, adult services and public health. I'll put my pen down. I'll stop clicking then. Is everybody happy with those 2 as we're going through? Okay. We've then got the 2nd of December, the CCG mid-year performance, and we will have at the September meeting as well the report back from the CCG on the mergers and amalgamations, so that will be added into that. Okay, everybody happy with that?
Chair.
Yeah, so
given what we've just heard about the confirmation of appointment of a new chief executive of the hospital, we haven't really got any hospital related reports until December, but I think it might be helpful for us to at least have some introduction from the new chief executive. just to sort of set the scene? And is there any possibility, perhaps, you know, through Sharon, that we can make those arrangements? Because we previously have really struggled to get the chief executive at our scrutiny meetings, and it would be quite good, I think, to you know, make our request quite early on.
We could perhaps try and do something informally. Obviously, if the committee's for reports, isn't it? So if we just wanted an introduction, we could perhaps do that informally. And if I might just add, Chairman, the September meeting is a special meeting, which was for mental health services, as opposed to an ordinary committee meeting. So it's perhaps the October meeting we need to add the report from the ICS into.
Okay, then. All right. Is that agreed then that we leave that? My only thing with the chief executive, I don't know when he'll be in place, because if he's not appointed for the next sort of week, 10 days, whether he'll be in position to actually come to any sort of meeting or anything. But we will follow that up and try and get the information as soon as possible. Okay. Maybe, Sharon, once he has been appointed, do you think you could just
or she?
Oh, yeah, or she,
or she.
Or she. Yeah, sorry about that. Once they've been appointed, do you think you could just get a sort of a snapshot of who they are, where they've come from, and stuff like that, and circulate it to the committee members so that they've got some idea as to who we're actually getting? Okay, right. So we're going to have the October meeting, we'll have the extra reports, and then the December one and the February one. Is everybody happy with all of those? Okay. And then we've just got...
Sorry, Adrian, I think at that one we definitely need the chief executive.
Which one?
December one.
December,
because Blackpool Teaching Hospitals are giving us a report on restoration of services. So
yeah, okay. So we definitely could pencil that in somewhere, Sharon, and tell whoever needs to know at the trust that we would like him to attend on that particular day. Okay. And then we've just got the March and the June one. Is that everybody happy with all of that? And
Chair,
then we've got...
sorry, can I make a suggestion, please?
Yes, by all means. Don't guarantee that we're going to accept it, but you can make a suggestion.
I was just really interested in the coast system and obviously the bronze, silver and gold, but we haven't got a breakdown, and I wonder if that could come back to the committee so we know which wards are performing well or which ones aren't performing so well. It'd be really, for me anyway, I think it'd be really interesting to find out some more if members are agreeable.
So should we put that into the work programme as well then? Yes, everybody seems to be nodding, so thank you very much for that suggestion. We will take it on board then. Have you got that, Sharon? Jolly good. Just check that Sharon is not going to tell me off at the end of the meeting, that's all. Right. And then we've got the scrutiny review work. Informal review ongoing. That's the support for mums during pandemic health visits. Everybody happy with that one? We've got the Meals on Wheels, which is the 6th of July for those members that were on it. And then we've got November scrutiny review of supported housing. I'm not seeing anybody screaming. And then we've got the 22nd of November, and we're looking at a joint meeting with Children and Young People Scrutiny Committee. I'll let Paula chair that one. And then we go into 2022 dentistry and oral health. If anybody's got a preference that they want to change these around, then by all means shout. I'm not saying that we'll do it, but by all means do it. And then population, excuse me, March 22, population health management, and then dementia. And then we've got healthy weight scrutiny review, which should be sometime in 21. Okay.
Yeah.
So we will be looking for people to come onto those. Councillor O'Hara?
I don't know whether it's worth it, but we did have a training session on dementia going back, I don't know how long. I'm just wondering whether it would be worth looking to have a recap and a training day for members who weren't in the council at that time.
Sorry about that.
We can have a look into that and see if we can get the trainers and see if they're available to do that for us, or see if there's anything as an alternative we can provide, if that would be useful.
I can deliver one of those sessions if necessary. I'm a Dementia Friends champion if that's needed.
Okay. Is there anything else on the work programme that anybody wants to raise?
Adrian, sorry, Chair, about the problems that we've got at the moment for residents requiring ear syringing or other matters relating to ears. A lot of people have struggled a lot over the last few months or several months, and that's still not resolved yet, is my understanding, from information that we've got from the CCG recently. And a lot of people are now really struggling with hearing because of problems with their ears that can't currently be resolved within the NHS system. So I wonder if that's something that we ought to review at some point reasonably soon as the NHS moves forward and starts to re-implement services that have been lacking.
Right. Who?
Chair, sorry, do you want me to pick that up and ask the question? Because I know that we're meeting, aren't we, next week for an update. So if I email and try and get an update on that and where we're at, because I know it was national guidelines, wasn't it? I'm happy to pick that up, Michelle.
Are you happy with that then, that Councillor Farrell picks that up and comes back with a reply to you?
Yeah, that's fine. And then maybe we can see whether we need to take that forward on a more formal basis at that stage when we've got your response. Thank you, Councillor Farrell.
Okay.
And I just, sorry to butt in there, but I thought I'd heard somebody when I was in the chemist that they had to now pay to get ear syringe because it wasn't under the National Health, same as varicose veins and a few other things to do with your feet. So I don't know how true that is, but I've heard that from a few people now that they've had to pay because it's now not on the National Health.
Can I jump on that one, please, Kim? Just answer that question for you.
Hang on. You can all put your hands down. I've got you written down. All right. Councillor Scott first. Then I'll come to you, Maxine.
Yeah, that's quite true, Kim. The charges are somewhere between 40 and 50 pounds for ear syringes. So obviously this is a growth industry at the moment because obviously the NHS isn't doing it. But I don't know the qualifications of these people. I've not heard how legal they are. I